Hi, sir. Hi, Pudi.
Hi, Bhavna. Hi, sir. Good evening, sir.
Hi, good evening. Hi, Bhavna, good evening. Yeah, Bhavna, can you just check your PPT? Can you share? Yes, great. Yeah. You are presenting only one article now? Are you going to show any other reference article? Can you unmute?
Yes, sir.
Okay.
I'm showing few other reference articles also.
Okay, okay, okay. Great.
Yeah, because this was new for me as well, so I didn't understand it first time I read it.
Okay, okay, okay.
Yeah,
Yeah, yeah,
just
looks very simple, but I don't know why then if it is so simple, then it's easy to. Probably, I think reproducibility may not be good.
yeah,
Yeah, that may be a problem. Otherwise, it's a relatively simple one. Hmm.
yeah. Actually, they've been trying to do from 2001, but if it is not being used like routinely, that means there must have been something
Okay,
that we
okay,
are missing.
okay, okay. Yeah. So, are you back to India?
No, sir. I'm still in UK.
Okay, fine. And you don't have a duty today?
I took off to present.
Okay, okay, great.
Otherwise, it's like 3:30 here.
Yes. Hello, ma'am. Elizabeth, ma'am. Good evening.
Hi Rajesh, hi Bhavna.
Hi, ma'am. How are you?
Yeah, I'm good. How are you?
I'm doing fine, ma'am.
I heard you say it's 30. Did I get
3:30.
that right?
Yeah, yeah, 3:30. Hi, ma'am. Hi, Priya, ma'am.
Hi, Bhavna.
Hi, ma'am. Nice to see you.
Yeah. Can you imagine where are we?
No, are you in London?
We
We
are
are
in
in Goa.
premises to check the premises. Where
Oh, that is so nice. Oh, come on, there's Nilay as well. Hi, sir. Hi, sir.
So, when did you reach?
Hi.
It's supposed to be tomorrow, no? I thought you are going tomorrow. Okay. You already reached.
Tomorrow we are leaving. The morning we are leaving.
Okay,
Yeah.
okay, okay.
How
the,
many of you are there?
the property is very good.
Oh.
Elizabeth, one room is vacant. Want to come?
Yeah,
So
nice.
nice.
Oh, that's
Hi,
nice.
hi, Nilay. So nice. I'm just so looking forward to be there.
Yeah, please come, Nasi.
So I'll switch off the video, mute myself. Yeah.
Hi, Vimal. Good evening.
Hey, good evening.
Hi, sir. Good
How are
evening.
you? Good
I'm
evening.
good.
Oh, Dr. Magesh is there. Hi, Magesh. Good evening, man. Long time.
Are you at work, Bhavna?
I took off to present, sir.
How is the weather in Sussex? It's
It's looking
cooled down.
gloomy.
Gloomy again, isn't it? Yes, I can imagine. You've not been to the coronation of the new king? Not going to London and all that?
I'm not such a favorite of the monarchy.
Mm. Once in a lifetime. Well, you don't know. The the new king may still die, and it may not be once in a lifetime, but at least twice in a lifetime achievement. This one.
Yeah, he should hear you, Vimal.
Queen and the country we are used to now. We have to start saying king and the country now. That's a problem.
Shall we start?
Yes, 8 to 1, maybe couple of minutes we can wait. Then we can start anyway, all dressed already. Bhavana, how much time it will take for presentation? Approximately.
I think my presentation is, I think, less only, so 15 minutes perhaps.
Okay, yeah, I can have 20-25 minutes, maybe ideal. Yeah.
You can talk slowly, Bhavana.
Okay, ma'am.
You can repeat
Rajesh,
like 2 times.
Hi, Magesh.
hi everyone. Hi,
Hi,
how are you?
sir.
Yeah, hi. So how the preparations are going on?
Yes, yes. Yeah, we are missing
for
you.
No, actually,
Yeah,
little bit late. I am able to join. Sorry.
okay.
Is it started the meeting?
You know, anyway, have you booked your tickets for Goa?
Yeah. Everything.
Yeah. Okay. Good.
So
Anyway,
it'll
so
be,
the
I
program
think,
is
14.
almost ready. So
Yeah,
we have to
16th.
get
Yeah.
the from the international speakers. We have to get the talk, everything, and very
Okay.
few people are coming from MGH and Dr. Chiara.
Okay.
Yes. So after
How many delegates? Approximately 100?
I think so
will
far,
be there?
yeah, about 80 people has registered so far.
Okay, fine.
Yeah, I think we'll reach 100 easily. Yeah.
Yes, fine. That will be a good crowd.
Yes.
Okay.
Okay, fine. So then
Fine.
we'll start.
Yeah.
Okay. Good evening, all. So for today's Journal Club, I welcome Dr. Bhavana. So she's going to present from UK, and she took off for presentation. I thank Dr. Bhavana. And today she is going to present on the prognostic value of the resting coronary flow, which is assessed by phase contrast MR, which looks relatively simple study, and anyways today she is going to explain the role of PC MRI of the coronary sinus in a suspected coronary artery disease, and what is its role and its prognostication, all those things. So at the end of the talk, then we'll have a good amount of discussion. Yes, over to you, Dr. Pavan.
Thank you, sir, for the introduction. So as sir described, this is a journal that was published in 2021 by a group of radiologists from Yokohama City Graduate School of Medicine in Japan. So this is about prognostic value of resting coronary sinus flow, which is determined by phase contrast cine-MR in patients with known or suspected coronary artery disease. So before we get deeper into the journal, this was a new topic. I mean, I had never heard of either resting coronary sinus flow or coronary flow reserve. And these are the two terminologies that are used extensively in the journal. So I thought I'll discuss about this first before moving into the journal. So coronary flow reserve is defined as the ratio of coronary flow under maximally induced hyperemia to baseline flow. It denotes the myocardial reserve vasodilator capacity. Decreased coronary flow reserve has been associated with increased cardiovascular risk factors like hypertension, diabetes, and hyperlipidemia. It acts as a useful index of the functional impact of coronary artery stenosis, just as we see in stress perfusion. And it is sensitive in predicting major acute cardiac events than by just measuring the percentage of diameter that is done using CT coronary angiography. So usually the unit is ml per minute per gram, but in MRI, it is just ml per minute. So to understand it further and to understand the difference between FFR and that is the fractional flow reserve versus coronary flow reserve, we need to understand the physiology of the coronary arteries. They can be divided into three segments. That is the major coronary arterial segment, which are more than 400 micrometers, where the main stimulus is due to flow, and the microcirculation, which consists of all the arteries that are less than 400 micrometer. So these are the main site for any changes that happen in microcirculation and are the main site for action of adenosine. So as we all know, whenever there is a stenosis, there is a decrease in flow and then the pressure, and there is vasodilatation that occurs in microcirculation, and hence we are not able to functionally assess the stenosis, and that is the utility of fractional flow reserve. So if there is any stenosis or pathophysiology that affects the macrocirculation, we can determine the functional stenosis using FFR. But any changes, like whenever there is a microvascular dysfunction that affects the microcirculation, FFR cannot determine it. So this is where the utility of coronary flow reserve, or sometimes also referred to as myocardial flow reserve in PET imaging, comes into play. So whenever there is change in resistance, this can be picked up using CFR or called as MFR. So this has been studied well in almost all modalities. In invasive coronary angiogram, we know how the FFR is calculated. We measure the pressure distal to and proximally in the aorta after physiologically inducing ischemia, mostly using adenosine. But to calculate the coronary flow reserve, this is usually done by intracoronary Doppler or using thermodilution. So another deeper technique that is used, an invasive technique to calculate CFR. PET is considered the gold standard for the quantification of CFR, where they refer it to as myocardial flow reserve. And the resting myocardial blood flow ranges from 0.4 to 1.2 ml per minute per gram. And during stress, it is expected to increase normally by at least up to 3 or 4 times, where it is around 2.8 ml per minute per gram. So the mean comes to around the mean myocardial flow reserve. That is, by dividing the stress by rest, it comes to around 4. So this is what that is used in PET. So just an example, I don't want to delve deeper into the physics of how it is done, but this is just a stress PET, and the images are acquired with time in a video, and the myocardial blood flow and the myocardial flow reserves are calculated using mathematical models by a software. So MRI has tried to catch up with PET to assess coronary flow reserve. So what was done, this was published in 2001, and again, a group of radiologists from Japan, they tried to see if they can use coronary sinus blood flow to quantify coronary flow reserve in patients with coronary artery disease. And they tried to do the study both using MRI and PET, and they found that the measurements were corresponding. Now, if you think about it, it does make sense, because all the blood that flows through the myocardium enters the coronary sinus. That includes the blood that is flowing in the epicardial arteries, that is a microcirculation, and also the microcirculation. So the coronary sinus acts like a reserve, and it actually is affected by changes that happens not only at the microcirculation level, but also at the microcirculation level. So this was the concept that has been used for quite a long time, interestingly. And this is the reason why they have used the coronary sinus blood flow, and they wanted to see if it has any prediction towards major adverse cardiac events. Then I had a question when I was doing this study, why they have not calculated coronary flow reserve. So that the reason being that just 1 year before, there was another journal that was published in JCMR again. And the same, I think the group of radiologists from the same university hospital, they tried to assess coronary flow reserve, and they wanted to know if it provides any prognostic information for patients with diabetes mellitus. And what they found was that the coronary the coronary flow reserve was reduced in patients with MACE compared to patients without MACE. But they also saw that the coronary sinus blood flow at rest was also reduced. And they were not sure why this was the case and why it was reduced and what is the pathophysiology behind it. And they suggested in their journal that another study has to be done to validate why this happens. So I think in 2020, this was published, and 2021, the study was extended, and they tried to cover all the patients with coronary artery disease, and they wanted to assess what happens with coronary sinus blood flow, but they also studied coronary flow reserve as well. So this is a retrospective observational study, and they initially tried to get 1,290 patients, and out of them they selected 1,276 because they had excluded 4 who had a persistent left SVC, and 10 were excluded because of low image quality, and 64 patients were excluded because they were lost to follow-up. So they had 1,212 patients for final analysis. And they used a 1.5 Tesla CMR, that's a Philips machine. And they did it the same way as we normally do a CMR doing the stress perfusion. But I was a little disappointed because they had not described how exactly they did the coronary sinus blood flow. They just mentioned in the journal that, you know, they took an imaging plane and they took a slice perpendicular to the coronary sinus up at 1.5 to 2 centimeters from the ostium on the axial cine images. And this was a picture that was produced in the journal, where they showed the coronary sinus, and they've drawn an ROI around the coronary sinus and an ROI in the myocardium for phase offset correction. And this is the graph that was obtained. So as you can see, coronary sinus has 2 peaks, one during the systole and one during the diastole. And they measured the coronary flow with time. And this is an example where this patient had a resting CSF-BF, that is coronary sinus blood flow of 96, and at stress it was 254, and the CFR by dividing these two came up to 2.6. But the journal that was published before this one explained in much more detail how they obtained the coronary sinus blood flow. So they did axial, first the transaxial images of the heart, and they tried to locate the coronary sinus in the transaxial plane. And from there, they took a slice perpendicular to the coronary sinus as seen in this picture, and that's how they did. So this article that was published before gave much more detail into how they did it, and rest is similar, rest things are similar. So I think the study they started doing from 2009, and the 2001 article, which initially described about coronary sinus, perhaps was from the same institute. So it was easy for them. I think that's why from 2009, for all the patients who had an MRI, there was coronary sinus flow. And then they used calculations. They calculated the change in the coronary sinus blood flow by calculating the coronary sinus blood flow during infusion and at rest, and also coronary flow reserve by calculating the ratio between the coronary sinus blood flow during infusion and also at rest. And to complicate it further, they did another calculation. They calculated rate product by multiplying the rate pressure product by multiplying systolic blood pressure into heart rate, because their idea was that the coronary sinus blood flow changes with variation in blood pressure and heart rate. So they wanted to exclude that variation. So they also calculated myocardial blood flow at rest by dividing the coronary sinus blood flow by LV mass. This is something that is the similar thing that is done in PET as well. And they calculated corrected myocardial blood flow at rest by multiplying the myocardial blood flow by rate pressure product and dividing it by 7,500. And the explanation they gave was they calculated this from healthy volunteers with mean age of 50 years. reported in previous studies. So as we see further, we realize that this was not that much of an importance, but they've anyways calculated it. And these were the patient characteristics that they took into account. And as you can see that when we compare patients with known versus suspected coronary artery disease, there were some differences, significant differences in terms of the sex of the patient, and also the cholesterol levels, the LV mass, the percentage of LGE, which was more in patients with known CAD versus suspected coronary artery disease. And also the percentage of ischemia was higher in patients with known coronary artery disease versus suspected coronary artery disease. So when they measured the coronary sinus blood flow, just like in the previous journal that they published on diabetes mellitus, it was seen that the patients with MACE had significantly higher coronary sinus blood flow at rest compared to those patients without MACE. And even the coronary flow reserve was more in patients with MACE compared to those, was less in patients with MACE compared to those without MACE. And the similar changes were also observed in patients with suspected coronary artery disease. So that was their first results. And also when they looked at the annualized event rates, so irrespective of whether there was LG present or absent, and also ischemia, if it was present or absent, the main determination factor was the coronary sinus blood flow. If the coronary sinus blood flow was more than the median, irrespective of presence or absence of either LG or ischemia, the annualized event rate was higher in these patients compared to those patients who had a coronary sinus blood flow less than the median. And when they did a multivariate Cox regression analysis to assess the risk factors, so as you can see that the percentage of LG and the resting coronary sinus blood flow were an independent risk factors for MACE. And the area under curve also suggested that patients who are having coronary sinus blood flow more than the median had a area under curve of 0.73 and 0.82 in known and suspected coronary artery disease. And the CFR was also around 0.72 and 0.83 in these patients. But as you can see, even the percentage ischemia on perfusion was also high at 0.8 and 0.79 in known and suspected coronary artery disease. So again, suggesting that coronary sinus blood flow helps to predict MACE. And again, they have done complex calculation of myocardial blood flow. This didn't show much of a change in terms of predicting MACE when compared to coronary sinus blood flow. In fact, the resting coronary sinus blood flow was enough to predict MACE rather than doing the corrected MBF at rest. So the limitations of this study was that this is a retrospective study and a single-centered study. So we don't know if the values they've taken can be extrapolated generally. And they excluded all patients who had metallic devices like pacemakers or intracardiac defibrillators. So we don't know what happens in these patients and we cannot extrapolate into them. And the other major limitation is also that coronary sinus is a very small structure, 2.5 millimeter at mid diastole. So really need to be accurate in drawing the ROI and obtaining the calculations. And they didn't explain the relationship between why the resting CSF, coronary sinus blood flow was higher in patients who had MACE. The link was not clearly explained. Perhaps this is because this coronary sinus blood flow is already elevated at rest due to patient having coronary artery stenosis, microvascular dysfunction, or probably both. Whereas the reserve capacity for pharmacological stress is decreased in patients with MACE. Maybe this is an explanation which I found in another journal, but they have not described it in detail. So in conclusion, in this journal, it is suggested that the coronary sinus blood flow is high for predicting future MACE, both in known and suspected coronary artery disease. and this can be used as an adjunct, and it is a non-invasive technique, and we don't even have to do a stress study to determine this. So perhaps may give more information about maze when we do it, if we have to do it without giving pharmacological stress. But the questions that arise after the study is like, can we really integrate this into routine practice? Because currently it's a challenge. There are a lot of journals that are coming up, and mostly from Japan. They're trying to see if it can give more information, especially about microvascular dysfunction, which we fail to describe when we do a stress perfusion. And the other two things that are extensively described in PET is its diagnostic value. So they talk about balanced ischemia, especially in patients who have like triple vessel disease or diffuse atherosclerosis. Can we reliably use stress perfusion and exclude significant coronary artery disease is one question. And what about patients with chest pain and no obstructing coronary artery disease? Can we really reclassify these patients if we see microvascular dysfunction, and if we do the cardiac MRI and we see that the coronary sinus blood flow is higher? Can we reclassify these patients? And in PET, it is very clear that they use it for prognostication. If the coronary flow reserve, what they call as myocardial flow reserve, is more than 2, they are saying this has a high negative predictive value. It is very good at excluding severe coronary artery disease. And if the CFR is less than 1.5 or the myocardial flow reserve is less than 1.5, irrespective of what the stress PET suggests, these patients are at higher risk of MACE. So this is just one example from PET that I found interesting. This was an 81-year-old patient who had chest pain and underwent a PET CT. So in this, we can see like there is mild reversible ischemia that is seen on, that is appreciative on stress images compared to the rest. So there is mild reversible ischemia in the LAD territory. But when they did the myocardial flow reserve, it was noted that, like this is the advantage, again, another advantage of PET, that it can give segmental flow reserve capacities. So here the LAD territory had no myocardial reserve, and there was some myocardial reserve in the RCA territory. So such a significant difference between how mild the findings are on stress versus what it shows on the myocardial flow reserve charts. So when this patient had an angiogram, this patient did have a severe mid-LAD disease. So so in PET, at least if they see that like the myocardial flow reserve are very less compared to what it shows on PET, they upgrade the patient into a higher probability of coronary artery disease. So can we use this in cardiac MRI is the question. Thank you.
Yeah, thank you, Bhavana. It's a nice presentation, but I feel there are a lot of problems in the study. Anyway, it needs to be reproducible, and definitely multi-center studies are needed. And the other thing is they're not given any cutoff to call it as elevated or reduced. Can you show that chart where they've given the normal and the elevation? There is, I think, significant overlap of the values, something like 80 versus 110.
Yeah, sir. I think there is a range that they have given.
Yeah, only they given a range with plus or minus 40.
Yeah.
Is
the
this one. Yes. So if you look at the value of the 84 plus or minus 30 versus 114 plus or minus 45. Yeah, so maybe for a group of people it may be useful, but yeah, I think they have not given any clear-cut cutoff when to call it as elevated or the normal value. That is one thing maybe you have to assess.
Yes, sir. I think I agree that that cutoff is not as clear as it is in PET. It is much more narrower, the range. So there will be like lot of overlap. There's a chance that there might be lot of overlap.
Yeah, and the other thing is, I think they mention it as this is a breath hold sequence. So to get a breath hold sequence of such a small vessel, you really need, and but they not mentioned. I think what is the total scan time. So even though they've given the other numbers and all, so but the slice thickness of 6 mm, yeah, normally will take about 7 or 8, but in a pediatric now we can take 6 mm. The field of view is okay, but with this I don't know whether we'll get a very good resolution with a breath hold of say maximum even a 15 seconds breath hold. Maybe we have to see whether we'll get a very good resolution to see the coronary sinus. Okay, any
Yes, sir,
comments?
I've never tried doing this, so yeah, I'm not sure, sir.
Yeah, we have seen for the pulmonary veins and all. This is adequate, but coronary sinus. Some people it is slightly bigger, but some people it will be really flat, and to get a good value, probably I don't know whether if you do with the free breathing, whether it will affect anything further. That you have to check. Yeah. Any comments from Vimal?
Few things. I came across this concept a year and a half ago or a bit early, and we were trying to bring in the myocardial blood flow reserve, and we don't have the softwares to do that. So if you do the stress and the rest, and be able to segment-wise quantify the myocardial blood flow, because we see a lot of cases where we are not very sure whether this is balanced ischemia, microvascular dysfunction, especially in hypertrophic cardiomyopathy. We wanted to bring this up, and that's the talk about CSF, so not CSF, coronary sinus flow. I tried it. It works well. You get it. Especially at stress, it is much better because you get more blood flowing through. It comes out well. At rest, it is little tricky because the coronary sinuses are not that big. The coronary sinus flow is not that good at that point. So it is good. I don't think Rajesh has clearly pointed out the range is so wide. You really cannot say whether it is useful or not. But the flow reserve is very, very strong value. And that value of 2 plus or below 2 is a very important turning point. And we are trying to bring in with some softwares to be able to do myocardial flow. So every normal stress that we do, perfusion itself, we want to be quantifying that. And that has also become very, very shall I say, acceptable thing now, just like what PET CT or SPECT will do for us. So I think that's the way for us to move forward. Problem with this is it doesn't really help us in coronary artery disease if there is significant one vessel disease or not. It's extremely useful if you're looking at microvascular dysfunction or an overall pathology. But if the coronary blood flow is used or myocardial blood perfusion is reduced, you do not know if it's a single vessel disease, double vessel disease, or triple vessel disease. So that way it doesn't help. So you have to do your perfusion. You have to do this as an extra thing, but it works well. I think I have tried in about 3-4 cases. It worked well. 3-4 cases on one day, just out of interest, they could see it. We need to.
How long does it take, sir?
It's simple breath hold, 12 seconds.
12 seconds.
12
So,
seconds.
I mean, the one article, I mean, one journal previously published, they said they do the rest first.
Yes.
And then do the.
So essentially, you would do your normal cines, the 2-chamber, 3-chamber, 4-chamber. That's what we would do, normal cine images. Then we give stress. Then we do short axis cine, and then we do delayed. So in this, if you're going to do this 2, 3, 4 chamber, do a Q flow. Okay, do a Q flow of the coronary sinus, stress, perfusion of stress, then do the don't stop the adenosine, keep the adenosine going, and the CSF coronary sinus like that.
Yeah, looks feasible, but whether we will get a consistent results, and maybe we have to first of all identify what is normal, and the range of normal probably we have to check in our own population. Then only we can identify. But if it works, even if it says that patient likely to have a coronary artery disease, whether it is single vessel or multi vessel, that is okay. So then we can do the imaging, further imaging with the CT or with the perfusion scans, and because it can be used as a screening modality then. Because especially if you are using without stress, and if you can get a resting flow, just by looking at that resting flow, if you can say that patient's probability of having a coronary artery disease is high, whether it is single versus multi-vessel, but still I think that will be a very good modality.
It will be, but as you said, the range for that is too high.
Yes. So that is the major problem going to be. Yeah, maybe if you can do, since if it is just a single breath hold sequence, maybe we can try doing it for all cases, and we can see how it works.
I think there are a couple of things which also happen in there, because if you look at it, it also depends on the hypertrophy, LV hypertrophy present or not, will determine what is your coronary blood flow at rest. So if male versus female make a difference. The indexing is not here. None of these indexing, body surface area and all that. Heart rate is also not calculated in resting flow. All of that will have a big impact.
Yes, yeah. So I don't think it will be very simple. Yeah.
And the presence of vasodilator also will have an impact on vasodilator.
Yes, and there are many other conditions where you can get an increased coronary sinus flow, like LSVC. If it is draining, definitely it is going to affect. So yeah, all those things also we have to look into it.
Vimal, you've done phase contrast of the coronary sinus?
Yes, we've done about 3 to 5 cases. It was, I was going to give a talk on advances in cardiac stress. And that's when I came across these and did a few studies. And it comes out.
Okay, and you did this, you did a true axial and did a perpendicular to it, and you got the coronary sinus?
So we do an axial black blood as part of our standard imaging plane, not cine images. Use that for the coronary sinus.
Yes, you see it in that plane itself?
Yeah, if you don't see it, then you will have to repeat it just below the 4 chamber, but you should be able to see it on that plane itself if your images are thin enough.
Again, what is the cutoff for coronary flow reserve?
2. Well, the normal is meant to be 3, 2.5 to 4 is the range.
Okay.
I think you, as long as it's about 2, then you're in a good range. MR, we are about 3, 3.5 currently.
So the 2 is for PET, right?
2 is for the PET, yes.
And MRI, you're saying is 3, 3.5.
MRI is also, I think, let me just show in this, at least in this in this one. They've used 2.
Yeah. So the myocardial blood flow, when you talk in terms of segmental distribution, when you're looking stress versus rest, not through the coronary sinus, there is a talk about it being at the level of 3, 3.5. No consensus on it yet.
Okay. So myocardial blood flow, do you have a quantitative assessment package? How are you doing it?
We don't have it, so that's why I tried this. We are trying to get it. As of now, we don't have it.
Why aren't you doing this clinically?
The coronary flow reserve?
Yeah, because you said it's not so difficult and it's 12 seconds.
I don't think it helps. The only scenario where it will really help is going to be when you have to differentiate between coronary artery disease and a microvascular dysfunction.
Okay.
Because if you've got, let's say, coronary flow reserve is low, but you have to demonstrate your ischemia, where the ischemia is. That's why you get patients sent to you. If you don't demonstrate that ischemia, this data is of not much use.
So if the coronary flow reserve is low and there is no ischemia, does it mean that there's microvascular dysfunction then?
Yes. That's what the concept is, that this is balanced ischemia, that we are not seeing it.
Okay, so then we can probably ask the patient to get something else done, or so we don't know how to treat these patients, is it? Like if,
Of
even
course,
if we
no.
can...
See, the microvascular dysfunction patients usually get put on aspirin and beta blockers. There's nothing else apart from that they can be done. But at least they do know that they have a problem, and that will explain their symptoms, and it's not psychiatric.
Okay. So probably in patients in whom they have a low pretest probability for coronary artery disease, it would make sense doing this extra sequence.
See, you have to be careful what you're talking about. So there are two things. If you're talking about resting coronary sinus...
No, the coronary flow reserve, that is the stress versus rest.
So yes, if you're doing a stress anyway, and you want to do this as an extra sequence on top of your perfusion imaging, it is useful in scenarios where you think the perfusion imaging is normal, but the coronary flow reserve is low. Then you can turn down and think about microvascular dysfunction.
Right.
If someone has a low pretest probability of coronary artery disease, then perhaps we should be doing a CT coronary angiography for them. That stress perfusion for them. But if you do end up doing that, I don't think microvascular dysfunction figures in that particular case group. Any patient suspected microvascular dysfunction, yes, this would be very, very useful.
Bhavna, that paper with, sorry, yeah, go ahead.
No, go ahead.
No, Bhavna, that paper with diabetes. Bhavna?
Yes, ma'am. Yeah, this one. Yeah.
Yeah. So in that, I didn't get what they actually...
Actually, this study was done before the one that I presented upon. So we wanted to study what happens to the coronary flow reserve in diabetes.
No, because this is the set of patients where microvascular ischemia is most prevalent.
Yes.
So I'm just wondering if they found a significant difference between diabetics and non-diabetic patients.
But then diabetics have coronary artery disease also.
Yeah, I mean, these
set of patients... That was a confounding factor.
Yeah, I mean, these set of patients, I think what the studies was, all the patients they had were, I think, diabetics. I can show you the article. And then they were trying to study if patients who had reduced coronary flow reserve had increased risk of MACE. That is what they wanted to study, versus diabetics versus non-diabetics.
So they were not looking at coronary artery disease versus microvascular disease.
No. So they were trying to study 309 patients with type 2 diabetics. And so mainly they were studying patients who had MACE and without MACE. So that was their classification.
So if you look at their conclusion, what they're basically saying is that if we do add CFR to all the known risk factors in this, does it help further classify this and non-risk groups? And the answer to that was anybody with a CFR of less than will be more MACE irrespective of anything.
So this was just, I heard it from another talk about PET. So in PET, what they suggested was patients with chest pain, if they are low risk, then we do CT or other things. High risk patients are taken to cath. In patients with chest pain, with classical risk, who are intermediate risk, those are the patients with classical risk factors, but with atypical chest pain, when they usually get PET, and they have noticed that 50% of the patients were reclassified either to higher risk or lower risk based on the results of perfusion and coronary myocardial flow result. So they said that it is a very powerful tool to reclassify patients in intermediate risk.
So that would be the typical patients then who get sent, because intermediate risk is the typical patients that get sent for imaging.
No, that paper, Bhavna, what you're talking about has to be taken in the right context. What they basically are saying is if you do perfusion imaging, it doesn't talk about myocardial blood flow alone. It just says about perfusion imaging using PET, low to intermediate risk. If PET is done, a lot of these patients will be positive and we push them into a high risk coronary. It's not about the myocardial blood flow reserve. It's just about any perfusion imaging.
No, sir. This one, I think they were talking mainly about myocardial flow reserve. So this.
See, because if you look at that classical paper which came out from the Nuclear Medicine Society, which see the British system is, and British and US system is to classify low to intermediate, intermediate to high group. Low group gets CT scan, intermediate groups gets nuclear medicine, or high risk get nuclear medicine or perfusion scans. And when they looked at that, very similar to calcium score, whereby if you do calcium score, the low risk groups get bumped up into an intermediate risk group. And with the nuclear medicine also, if you do the perfusion, because nuclear medicine does not do only myocardial blood flow, or does not only do perfusion, it does both together. So these go hand in within that. So when you do that, what they said is our report results have led to up classification of a lot of these patients. That up classification is part of, if you're saying it's purely on myocardial blood flow, which basically
you're
means,
right.
Yeah, it will not be, because then it will all be patients of microvascular dysfunction.
Yes.
It will not be patients of ischemia. So it's basically ischemia testing has upgraded a lot of these patients. My question, which I wanted to ask you, this is something I've been very lazy about and we don't do it. How many of you, in all your Q flows, you do background correction?
Actually, earlier we used to do with the in the GE system with the phantom correction, and which is very tedious, and of late we completely stopped it, so we don't do it.
Do you do it on the software when you're analyzing it, putting one marker in the muscle or something?
No, right now we are not doing anything. So
Others?
So actually, it's a very interesting question, because I think that it differs between what software you're using, because I mean, even I haven't delved into the depth of this whole background correction, but Philips in fact says don't use background correction, and then you have CBI 42 where we always use background correction, and then you have like Siemens probably doing something else. And so I mean, but then I don't know, like I mean, in on Neosoft we've while using it, we've looked at cases where it's not correlated, and then and especially in cases where there's quantification of aortic regurgitation and you're like struggling to get the actual regurgitation fraction, and then we use background correction in a few to just see if it makes sense. And then you start rethinking, am I actually I don't know, artificially trying to change the flow or quantify the flow, or should I just repeat it again, to get a better value? So I don't really know the answer to this, but I don't use it on, I don't use background correction currently, but I've used it in the past when I used a different software. How about the rest?
Elizabeth, any experience?
Yeah, we do it routinely, but I'm not sure if it makes a difference. I haven't tried not doing it and seeing if the values are the same.
I have tried. I do it with it, without it, and I see 1 or 2 ml difference, not huge differences, and I just stop doing it. But I do see a lot of people in Europe and US vouching by it. It's kind of become part of their normal practice. I really don't know the science behind it, whether that is robust enough. Should we do it or not?
No, sometimes
Yeah.
it gives a lot of error, the background correction things. So
So
One
what
place-
exactly do you, sorry, yeah.
No, ma'am, carry on, ma'am.
Go ahead, then.
No, one place that I found this background correction a little bit interesting is that sometimes in QFlow, in the analysis, I see a significant amount of regurgitation. But in the cine images, I don't see a predominant regurgitant jet, especially in IOTA or something like that. Then when I do a background correction, the baseline is modified by the background correction, and I get a new value with a very less regurgitant fraction. But I've noticed this in some patients, but I don't know how important it is or what is the inference of it.
Yeah, that's what I agree with Pudhiyaman, because even I do that, like when I feel like what value I'm getting is not correlating with what I'm seeing, or vice versa, then I end up doing this background correction to see if it makes a lot of difference.
So
But I still end up repeating.
The way you do background correction is put a reference value on the vertebra and propagate
So on a
it.
static,
Is it just that?
Yeah, on a static tissue, basically the anterior chest wall, like the muscle there, or the fat there or something, where the vessels are not there. So there shouldn't be any vessels.
So it's a very simple thing to do, right?
Yeah.
So is there any reason why we are not doing it or we are doing it?
The reason I don't do it is because I don't know how it affects the values. Is it adversely affecting the values, or is it making the values more correcter, or is it making more inaccurate? I don't know. For example, the background correction, the phase contrast is telling the flow forward, flow back. Background correction is only telling you what is the baseline in that. Now, if you change that baseline, it may change things significantly. I do not know.
How does the background correction change the baseline? What is the explanation behind it?
It basically says that it's looking at a tissue which has no flow in it. Nothing is changing there. So that's a static tissue. So that becomes the baseline. So if you, for example, by mistake, put a baseline correction in a muscle and there is a blood vessel going it, it will bump up baseline because it will catch the flow in that blood vessel.
So we typically use bones, not muscle. We use the vertebral body most commonly. Is that the right place to do it in?
The traditional teaching is something which doesn't have flow and something that doesn't move. Those are the two criteria.
So bone sounds just right, no?
I think so, yes.
Yeah, but when I used to use it, we always used the anterior chest wall and just avoided any artifact or any blood vessel.
Have you read it somewhere that you should use the anterior chest wall? Or
it's more going by what everyone else was doing, and that's what even I haven't delved deeply into this, but yeah, we should, I guess, because even I don't know the meaning of doing it or not doing it, because unless we're doing it for, like you're doing it for all patients, I do it for a few patients, and in those few patients are the patients in which there's some discrepancy in what I'm getting, and I don't want to repeat the scan if I can avoid repeating the scan. And sometimes it does make a lot of difference. So then I decide that, okay, let me just repeat the scan because I'm not sure which is right and which is wrong. Because everything else is calculated without background correction. So
That what
I don't know if it's the
Putyavan
noise
was
which
saying is just fascinating. That aortic regurgitation, it's easy to do and check it out, whether the values are changing.
I think the
Yeah,
values
yeah.
will change, but the question is which one is correct?
Yeah, exactly, right?
The one closest to the echo is correct.
I don't know if
Closest-
echo is always right. That's why we're doing the MR.
See, the echo will tell you mild, moderate. It's not going to tell you percentage.
No, it will tell you the velocity. It will tell you the gradient.
I'm not sure if the velocity will change. Okay, the gradient calculation for them is, to us, will be grossly different. And that's an accepted phenomenon. Because when they say there is a gradient of 60 millimeters of mercury, for us to achieve that kind of a gradient, you need at least 4 meters per second for us to achieve that kind of a gradient, which is not that common. And they have gradients of 100, 110, etc. in there. And I've never seen that kind of gradient achieved in MRI at all. So
but at least the height for us, say you got 30 and you got 60, and 60 is closer to the 100. So we can presume that the 60 is more correct than the 30.
But that's for stenosis. For the regurgitation, what will you use as a marker? Because here we are talking in terms of quantification of flow in regurgitation.
For which MRI is supposed to be gold standard.
True. So, of course, you can look at and say the stroke volume versus what flows in the aorta, but again, you're relying on another Q flow to tell you whether that is accurate.
So what I end up doing is like basically at the end of it, repeating flows at multiple levels to make sure that, I get some meaningful regurgitant value and something where the baseline is what I take as baseline is SVC and descending aorta as the net flow, and then and then do it below valve. And even if there is no mixed valve disease, I end up doing below the aortic valve and probably at another like above the aortic valve at 2 places, and then decide like what makes sense and then give them a regurgitant value. So I don't know which is better, background correction or what.
That doesn't sound like gold standard at all.
Yeah, exactly. But that just means that the other modalities are worse than what we're doing.
Pudi,
we don't know how to do it.
Pudi, what is your take after you've seen that? Do you do that for every case?
So not every case. In many cases, I don't find much of a difference. As you told, there is hardly a few ml of difference between background correction and without background correction. I also stopped doing it for every case, but I do it only when I feel that the phase contrast values are not what is expected from what I see in the cine images. Then I try to do it, and let me get this straight. It doesn't happen in all the cases. Sometimes the background correction doesn't help. It still shows the same regurgitation fraction, whereas I don't see a significant regurgitation in cine images. But in some cases, I have noticed that the baseline has shifted after background correction, so that the regurgitation has become much smaller than the one without background correction.
I think one should just either whatever one does, do the same thing for everybody. At least that way, the same error you're making for everybody, Like the way when we draw the endocontour, they say you either include the trabeculations and papilla or you exclude. So you stick to one methodology. Fooling around this way, that way, maybe more.
True. Rajesh, explain to us, I've never done this, so it would be good. I think others would not have done that either. When you said you did phantom correction, what was that? How did that work?
Yeah. That is one of the tedious process. What exactly? But no, it has worked in some cases really well. What exactly we'll be doing is
you start. I'll go and
congenital heart disease. What we'll do is, we will be doing the scan. baby scan, and then what you have to do is we have to keep the ECG of the patient, and we have to ask the patient to sit on the side of the couch in a table. Then exactly at the location where the heart was there, we have to put a phantom. Then we should not change the landmark and all. Okay, so then you just copy paste the all the PC scans which was not planned earlier. Copy paste the same thing and just mark it as a I'll mark it as a ball, so that I know what is the original and what is the ball. Then we have to, in the post processing software, it allows that we can select the background correction sequence. So then you have to select that sequence where the it will show that the region of interest exactly at the same location, because we have not changed the landmark anything. So that we have to repeat the same parameters, everything. Then the problem comes is sometimes what happens is it won't be in the exactly the same position. It may be it may be just partly in and partly out. In that case, the error will be too much. So because of those type of a problem, and especially patients with anesthesia, it is very difficult to keep the patient in a chair or like that. So then we stopped it. But it is really, it will take extra at least 20 minutes when you are doing say 10 sequences and all.
So I have a question. As Elizabeth ma'am told, stick to one, whether do background correction or don't do background correction. My question is the phenomenon of background correction, is it sequence specific or patient specific? Is there a factor, the patient factor, which affects background correction? Whether some patients background correction works, some patients background correction doesn't work. Is it something like that, or is it sequence specific? That if you are using one type of sequence without any change in parameters, you either use background correction or don't use background correction. Is it like that, or is it patient specific?
You are the physics guru. You answer that. No, I personally believe the background correction is a lot to do with the magnetic inhomogeneity. And that once you put the patient in, that field also changes. So there is a patient specific factor, which is always going to be there. And it is a magnet specific one, but magnet specific one will not change between one patient to the other patient, but the patient factors will change. The view in which you take, for example, if you take an aortic flow in an axial plane, but if you take an aortic flow in a sagittal plane, the background correction will vary, because there are other flows which come into the image, which will give the artifacts, which will make the problem of correction. So it is image specific, and that's why Rajesh says it has to be in the same location where it was done. And all the parameters have to be the same. So image specific, patient specific.
Maybe when we have a 4D flow, some of these problems may be rectified, because anyway we are acquiring the entire chest in a full volume, with any number of plane may be possible. So hopefully with the 4D flow, some of these problems will be rectified.
As it is, 2D flow is not accurate. It's 3D flow that is considered accurate. So when we say it's gold standard, are we referring to the 2D flow, which we all do? Or are we referring to the 3D flow?
What do you mean by 3D flow? I'm sorry. What's
the phase contrast study? What we use is a 2D.
Correct.
Yeah. But because the flow is in all directions, it is not a laminar flow. So many of the velocities are missed out, because it's all going in different ways. So you need a 3D phase contrast package to get accurate values. And I don't have a 3D package. So now I'm wondering, when we say that aortic regurgitation quantification by MR is the gold standard, is it really referring to the 2D package that we have, or?
It does refer to the cardiac MR as an entirety. I don't think there's one sequence, because you will use the stroke volumes, etc., also for quantification, along with phase contrast flow. I don't think it anyway specifies 2D flow or 3D flow, because we've all jumped from 2D to a very small people having 3D. We've all jumped to 4D straight away. There are very few centers which use 3D on their own. They all use 4D because you get the functional analysis at the same time. So I don't think there is much publications or much studies on the 3D flow alone. It's purely now 4D flow.
And it must be 4D flow which is accurate. Do you think 2D is accurate?
4D will be certainly more accurate than 2D, no doubt about that. But as it stands, 2D seems to be more accurate than your echo parameters. For regurgitation, for stenosis, definitely not.
I've done 4D flow on a few patients, aortic patients, and with regurgitation to like help me quantify it better. But 4D flow, currently the sequences that are available, at least the ones that I have for Philips, is not great. The resolution is not great, and it takes a long time also. So it adds a lot of scanner time. And because the resolution is not great, I mean, bigger vessels like aorta is good. I mean, you can still quantify easily, but when you go into like congenital heart diseases, also where I've tried, the smaller vessels and the vessels which are at angle, you're not really able to, you're just like assuming because the resolution is so poor. So, I mean, the current state of 4D flow, at least the sequence that I have, I don't think I can really rely on it. I've done it on a few patients and, you know, and then I haven't really relied on it. And, you know, I thought, I actually, when I started off, I thought I'll do it on aortic patients and congenital heart disease patients, but it adds so much scanner time that we just like stopped doing it. And it's only really if I need something, then I may just call back the patient to like put him back in the scanner for some time. So that's the situation of 4D flow here on my end. Actually, in this, I just had one question. You know, talking about flows, there is this real-time flow that can be done in constrictive pericarditis versus restrictive cardiomyopathy. What is that? What is that real-time phase contrast imaging? Is it available? Can we do it? Or is it a different sequence? I'm a bit confused, and I've read about it, but I've just not been able to understand.
It's not phase contrast.
No, real-time phase
Real-time
contrast
imaging.
in the SVC and pulmonary veins, and
Oh,
you know, to look at that.
Oh,
Yeah,
you're
to look at
talking
that.
about the flows in SVC and pulmonary veins and constrictive pericarditis.
Yeah, it's supposed to be quite a, like
Okay.
that Thiruvendranath, the guy in Toronto General. He's published a few papers on that.
Okay. I thought you were talking about the free breathing sequence. I was
No.
wondering why you were
Yeah, the free
bringing that.
breathing, but flows, but no, the phase contrast free breathing.
Yeah, there is a sequence. I don't have it, but it's very well known. It's also can track the valve also. So that is the real time scan. It's similar to the real MR echo or real time imaging what you are doing for constrictive pericarditis. So it will basically will supposed to produce the images in real time. So fast, but
Can we do this? Can we adapt the
no, I think
current
it will be a special
sequences?
sequence. Similar to the MR echo, it will be a different
Okay.
sequence.
Oh, okay. That's what I just wanted to understand if anyone else is doing it.
We do have the real-time sequence. I don't know if that is attached to a phase contrast.
Yeah,
There
even
is-
I have the real time, but then I don't know how to adapt it to the face contrast.
Don't know either. So we'll have to see that.
Yeah.
Yeah, I think here had a good discussion, and so it's 9:05. So anyway, today I thank Dr. Bhavana for such a wonderful presentation, as well as Dr. Vimal for starting this nice discussion on the Q flow. Yeah, I think it will be very useful for everyone to understand, and it's always good all of us in the same page now what we are doing, and now sharing our knowledge. So with that, I thank you everyone. Good night.
Thank you, sir.
Thank you, Bhavana. Bye.
Thank you.
Bye, bye, bye.
Thanks, Bhavna. Thanks, everyone. Bye. Good night.